All right, great. Well, I think we have a quorum to get started. So, welcome everyone. Thanks so much for joining us for, I think it's our third or so lunchtime webinar. We've been doing these to showcase uh, some new and in progress research that's been mostly on healthcare affordability issues. So, my name is Judith Garber. I'm a senior policy analyst at the Lown Institute. And now this is where I'm going to see if I see. I can resume. Great. Okay. So we're really happy today to have Dr. Justin Barnes. He is an assistant professor of radiation oncology and senior associate consultant at the Mayo Clinic in Rochester, Minnesota. He's also an advisor at Cost of Care, a nonprofit organization dedicated to cultivating change agents who will lead the creation of a more affordable and equitable health system. Justin's research interests include evaluating public policies and interventions to improve access to care and cancer outcomes. He completed his residency at the Department of Radiation Oncology at the Washington University School of Medicine. So thank you so much, Justin, for being with us. I am going to really quick put in a plug for our upcoming conference on healthcare affordability. So if you're interested in diving further into these solutions for healthcare costs, we want to see you at Lown 26, Confronting Healthcare Affordability. It's going to be a one-day conference in Cambridge, Massachusetts. We're going to have some panels really across the spectrum of healthcare sectors and also viewpoints. And our program is now available to see at lowninstitute.org/lown26. So you can go there to check out our early bird pricing, which is available until March 10th. And with that, I'm going to pass it on to Dr. Barnes. Just a note, a housekeeping note for everyone that we are recording this session and we'll likely share it to our network. I think we're going to record just the session with Dr. Barnes's presentation, and then we'll cut the recording for the Q&A, if that sounds good to everybody. So Justin, you should be able to share your slides now.
Sounds great. Well, thank you so much for the introduction and for inviting me to have a chat with you guys. Really excited to share some of the work we've been doing. Let me see if I can get my sharing to work here. Sorry, just trying to move the control bar out of the way. You guys are probably seeing presenter view. Is that right?
Yes.
Um, does
Nice.
that look right? Okay, perfect. Um, well, again, thanks for inviting me to be here. We'll be talking about a project we just published a few weeks ago, actually, end of January, high deductible health plans and mortality among cancer survivors. Um, so I guess some disclosures from my end. I work in the cancer space. I treat patients with cancer, and most of my research is related to how various policies and such can impact patients with cancer specifically. Um, and some of the work I've been doing is with this great cost of care organization. So first, a little bit of background, and I think this group's probably familiar with most of these things, but for sake of discussion, we can highlight a couple points that'll be relevant to the rest of our discussion here today. So we'll be talking a lot about high deductible health plans. Um, in essence, what these are, they trade um, uh, higher deductibles and sometimes the possibility for a higher out-of-pocket maximum for lower premiums. In contrast to kind of the opposite for traditional health plans, which carry kind of higher premiums but lower deductibles. Um, these plans are attractive to many people because they do allow for lower premiums and lower monthly payments. But for some, these can cause problems if there are excessive out-of-pocket costs. Now, why does this matter? We've seen an explosion in high deductible health plan prevalence over the last couple decades, increasing from about 15% to 40% over a kind of 15-year span. We expect that number to continue to rise under the current administration. I think this is also relevant. Recent surveys suggest that about 40% of U.S. adults can't afford a $400 expense with cash equivalent. And we know deductibles can be much, much, much higher than that. High deductible health plans, sort of in the general population, probably because of some of this, the concerns about being able to pay for care are associated with delayed and sometimes decreased care utilization. For patients with cancer specifically, uh, we've seen these types of plans be associated with delays in diagnostic workup, which can lead to more advanced stage cancer diagnoses, which carry a worse prognosis. Um, because of some of the delays in the diagnostic workup, there's also some kind of downstream impacts on treatment initiation. We've seen delayed or foregone health utilization even for kind of health maintenance types of things, higher out-of-pocket costs. In one report, these were up to 70% higher. This is important for patients with cancer who are on treatment. There have been other studies that have looked at even small increases in out-of-pocket costs impacting patients' ability to kind of stick with a treatment regimen. But up to this point, it's been unclear if these high deductible health plans impact survival. That's what we really set out to study. Three main objectives that we'll be talking about today. The first is determine whether cancer survivors with these high deductible health plans have an increased risk of death compared to cancer survivors with different types of insurance. Um, we also wanted to see if this effect of high deductible health plans was different for cancer survivors and sort of what we'll call the general population without a cancer history. Um, Based on some of our kind of hypothesized mechanisms, we also wanted to see whether financial barriers to care could mediate some of the potential survival differences associated with high deductible health plans. We use data from the National Health Interview Survey. This is sort of open, publicly available data, and there are linked mortality files through the National Death Index that we used. We studied participants in the 2011 to 2018 surveys. These are the most recent that are linked to the mortality files. We did include all adults up to the age of 84. We'll talk about this a little bit later. Um, there's a small percentage of patients with Medicare who have high deductible Medigap policies, and we wanted to examine those patients as well. For this study, we excluded patients with no insurance or Medicaid insurance, where high deductibles don't really apply. Um, High deductible health plan status is defined in the survey, and they utilize the IRS definitions. For the years of this survey, high deductible is defined as more than 1,200 to 1,350 for an individual, or twice that for a family. Um, and those numbers increased a little bit over that sort of study period. One of the limitations of this project is the survey basically asks participants, is your deductible more than this amount? And we have a yes, no, basically, in the survey. We also look at health savings accounts that some participants have in addition to the high deductible health plans. Our primary outcomes are survival. We look at overall survival as well as cancer-specific survival. Um, I'll just make a quick note. This is always relevant for my cancer audiences. It's not necessarily to what we call the index cancer, meaning the cancer that is reported at the time of the survey. It's possible that these participants in the survey could develop a different fatal cancer after the time of survey. We use age as the time scale for these analyses, and we use Cox proportional hazards models to look at the associations between high deductible health plans and survival. We account for the survey design and survey weights, account for various sociodemographic, as well as some limited cancer information that's included in the survey. We did conduct a few sensitivity analyses using a different time scale, using time since diagnosis, which enabled us to adjust for age at cancer diagnosis. Um, uh, One part of our study, like we talked about before, was trying to understand whether there were um, financial barriers to care could be playing a role in the presumed survival differences we would see. Um, the NHAS includes a few potential financial barriers to care. We looked at delayed or foregone care due to costs in the past 12 months at the time of the survey, cost-related medication underuse in the past 12 months at the time of the survey, um, worrying about paying medical bills in the case that the participants got sick or had an accident, and something that we call general financial worry. It's a sort of composite measure where participants reported being very worried on a Likert scale about money for retirement, medical costs, maintaining standard of living, costs of healthcare, paying for college, paying monthly bills, paying housing costs, or paying credit card bills. Um, I don't know how familiar this group is with mediation analyses. I imagine several of you are. But briefly, the way I conceptualize this in my simple mind, um, we suspect to see an association between high deductible health plans and mortality. Um, but we also know that high deductible health plans probably impact financial barriers to care. And we know that these financial barriers to care also sort of independently can impact survival. What we're trying to do in the mediation analyses is quantify how much of the effect of high deductible health plans is through this sort of mechanism here versus through this indirect pathway through these potential financial barrier mediators. Um, in our mediation analyses, we evaluate these various financial barrier mediators separately. We calculate the indirect or mediating effect with it's essentially the product of a couple model coefficients for the barrier to care model, where the outcome is survival, basically this effect here, as well as and combining that with the effect for the high deductible health plan on the financial barriers to care. We estimate variance using the Sobel method, and then estimate the proportion mediated by the mediator. Jumping into our results here, so our sample consisted of nearly 150,000 respondents. A small percentage were cancer survivors, about 6%. About a quarter of individuals had a high deductible health plan at the time of the survey participation. A little bit higher in individuals without a cancer history. Taking a look at what our sort of the distribution of the individuals who were part of the study, um, taking a look at some differences between the people with cancer and no history of cancer, as well as some differences between people with and without high deductible health plans. If we first take a look at the age groups, unsurprisingly, those with cancer tended to be older. There's quite a bit more, 65 to 84. Um, and you'll notice there are more individuals with high deductible health plans who are on the kind of younger side of things. Um, that pattern in terms of younger people having more high deductible health plans holds up as well with people with cancer, but the much fewer in the 65 to 84 year range, which is consistent with what we expect in terms of the incidence of cancer. Um, as expected, most of the high deductible health plans were among individuals with private insurance. Um, Interestingly, there's a slightly more people with high deductible health plans had higher educational attainment, as well as higher incomes. Also of note, there are more people with no comorbidities with high deductible health plans, which I think also makes sense. But that's more so for the individuals with a history of cancer. Um, uh, Maybe a little less relevant to this group that maybe deals a little less commonly with cancer, but this is sort of our breakdown of cancer sites. I'll just make a quick note. The NHAS has probably overrepresentation of patients who are expected to live a long time with their cancer, where cancer is more of a chronic disease. Um, and their patients with more aggressive, more fatal cancers are a little less well represented in this population. Um, Many of the patients are 15, 16 years plus out from treatment, a relatively even distribution based on these kind of timeframes. So a good spectrum of cancer survivors. Getting into our primary results here. So here you're looking at Kaplan-Meier curves of overall survival, and the timescale here is age. What we can see is that individuals with high deductible health plans, and now let's remind ourselves, these are more uh, uh, um, and this is just specifically the cancer survivors. And what we see is that these curves separate a little bit among cancer survivors, where individuals with high deductible health plans have worse outcomes. But in the general population of individuals without a cancer history, those curves are relatively similar. And we see that kind of pan out here in our um, Cox proportional hazards models, almost a 1.5 or a 50% increase at risk of death for cancer survivors who have these high deductible health plans, but very, very, very similar um, risks for individuals without a cancer history. When we look at whether these effects are different, we indeed do see a significant interaction. This is specifically the cancer-specific survival. Um, and I sometimes get questions about this. It's possible that people without a cancer history um, at the time of the survey develop a cancer after the survey that they could potentially die from. And that's what we're seeing here in some of these patients. Um, but again, what we're seeing is that there's a difference in even cancer outcomes for individuals, cancer survivors who have high deductible health plans. This is a really, really busy plot. I don't expect us to get a lot from the teeny font and teeny sizes here, but what I would like to look at is a little bit of patterns. So these are the hazard ratios basically across a bunch of different subgroups. The orange lines that we're seeing are cancer survivors. The kind of dark blue lines are individuals without a cancer history. What you'll see pretty consistently is that in the blue, these numbers are kind of spread relatively evenly across hazard ratio of 1 or null. Um, but these orange dots and lines tend to be more to the right, indicating um, worse survival with these high deductible health plans. Um, the dotted lines are overall survival. The kind of solid lines are cancer-specific survival. When we look at potential heterogeneity in the effects across these different subgroups, we really don't see much for overall survival. I would just like to highlight one subgroup in particular here, individuals with private insurance, primarily our under 65 group. There still is a significant impact. When we look at the Medicare group, those effects are sizes are pretty similar, but they cross the boundary of 1. When we look at cancer-specific survival, there's maybe some potential for heterogeneity. Interestingly, when we look at the highest income versus some of the lower income, the cancer-specific survival, again, so these kind of thick lines, we see the lower income and lower educational attainment subgroups, the effects get pulled more to the left, which is kind of interesting. We can talk a little bit more about why that could be the case a little bit later. Here's our results of the mediation analysis. We'll walk through some of this real quick. It's kind of I think, a confusing table until we spend some time talking about it. So this first column here, we're looking at the association between high deductible health plans and the barriers to care. So for example, high deductible health plans for cancer survivors are associated with a an odds ratio of 1.6, higher rates of general financial worry, higher rates of delayed or foregone care, and so on. On this next line, we're looking at how these barriers impact survival. And unsurprisingly, this is not new information by any means, but each of these various, what I'll call barriers to care, are associated with worse survival. When we jump into our mediation analyses, we indeed do see a significant mediating effect of these barriers to care on the association between high deductible health plans and survival. When we try to estimate what percent of the effect of high deductible health plans is mediated by these various barriers. It looks like anywhere from kind of 30 to 60, 70% or so of the total effect seems to be explained by these barriers. Uh, Real quick, talking about with or without health savings accounts. We look at this because some reports from my colleagues at the American Cancer Society, when they look at the impact of high deductible health plans on healthcare utilization, it looked like on their study that having a health savings account might mitigate some of the adverse associations. We thought we might see something similar here in terms of survival, but to cut to the chase, we didn't. Um, for individuals with high deductible health plans without health savings accounts, that's the majority of cancer survivors with high deductible health plans. You'll notice these kind kind of associations between high deductible health plans and survival are very similar to the overall analysis. We conducted mediation analyses in this subgroup as well that were very, very similar. Now, focusing on the individuals with a health savings account, um, presumably these are individuals who are contributing to the health savings account. We don't know that for sure based on the data we have, but we would hope that they'd be contributing to this health savings account and then kind of using those dedicated funds to help pay for healthcare costs. But for even those individuals with health savings accounts in conjunction with their high deductible health plans, they still had worse survival compared to individuals without high deductible health plans. Um, when we conducted our mediation analyses, the strength of the associations was much less clear across the board, with the exception of this measure about worry about medical bills. Um, it's kind of hard to know what to take from that. Just kind of summarizing some of the what I think are the most important points from this study, and then we can talk about it a little bit more. Um, what we've seen is that high deductible health plans are associated with an increased risk of both overall and cancer mortality among cancer survivors, regardless of the health savings account status. We saw that this association is much stronger in cancer survivors than in the general population, where there really doesn't seem to be much of an association at all between high deductible health plans and survivals. Um, the high deductible health plan status among cancer survivors was associated with increased risk of financial barriers to care. And those financial barriers to care seem to mediate about 30 to 70% of the total association of high deductible health plans with survival. Talking a little bit about why. Um, I think there are kind of two potential mechanisms at play here. The first is that we uh, kind of know from prior reports that high deductible health plans seem to financially disincentivize individuals, particularly cancer survivors in this case, from utilizing necessary medical care that they need to optimize survivorship. Um, and we think that kind of decreased use of necessary medical care could thereby compromise survival and cure. Um, we also think that these high deductible health plans, based on some of our additional mediation analyses, may also lead to a greater degree of financial toxicity. And other reports in the cancer space have shown really strong associations between financial toxicity and, for example, severe bankruptcy is associated with a much, much, much higher risk of mortality from cancer in some prior reports. Um, I think this potential mechanism here in terms of disincentivizing necessary medical care um, is relevant, especially as we think about why we might see an impact of high deductible health plans in the cancer survivor population, but not in the general population. We know that cancer survivors have much higher requirements for medical care in the future, not just from a cancer treatment standpoint, which obviously is part of it. And unfortunately, we know that um, many of our patients with cancer develop relapse disease and need subsequent treatment in the future. But there's also significant I guess, burden we can say of medical needs with regards to managing long-term complications and toxicities of treatment, as well as surveillance for kind of monitoring for those effects, as well as monitoring for recurrent disease. Um, we expect much less of those medical needs in the what we suspect are the kind of general population with high deductible health plans that, in general, are relatively healthy. Um, Talking a little bit about some limitations, uh, it all kind of revolves around this kind of retrospective survey nature of these data. Certainly some survey bias and probably some selection bias in terms of who are getting these high deductible health plans and who is getting health savings accounts. Um, One potential confounding factor here, and we don't have a good way to test this, but we wonder whether cancer survivors who are experiencing more financial toxicity because of their treatments are more likely to choose high deductible health plans to help lower their premium costs. Um, it's also possible that individuals with high deductible health plans are just that could this be like a surrogate for baseline willingness to seek medical care? Um, darn autocorrect likes to change HSA to HAS, and I missed this one. Um, but there are likely some differences in individuals who have and don't have health savings accounts. Um, for example, the employers that offer health savings accounts tend to be larger firms. Um, High deductible health plan definition is set by the IRS basically and adopted by the NHIS. And we don't really know what individuals' deductibles are. Along with that, the high deductible status is self-reported, which has its own problems, as we know that many consumers really aren't sure what their deductibles are. Um, Another limitation is just based on the time point at which we capture this information. The high deductible plan status is based on the time of survey. The financial barriers to care are based on the time of survey. Um, uh, it's certainly possible that cancer survivors had a different plan when they were diagnosed. It's possible they had a different spectrum of financial needs and issues they were facing at the time of their initial cancer diagnosis, and not having some of these issues at the time of the survey doesn't preclude them from developing some of the issues in the future. We have really limited information from a cancer standpoint. We don't have cancer stage information. We don't have the types of treatments individuals received. We don't have information about recurrences or complications from these treatments that certainly could impact a lot of these outcomes. Um, and I think I mentioned this before, but there aren't a lot of individuals with recently diagnosed cancers, and individuals with aggressive disease are somewhat underrepresented in this cohort. If you take nothing else away from today, it's hopefully a couple of these points. Just a reminder, what we saw from this study is that high deductible health plans are associated with worse survival in cancer survivors. And we think this is at least in part due to high deductible health plans' impact and worsening of some financial barriers to care. I think these data underscore the importance of educating the public, as well as for those of us who see patients, counseling our patients about uh, potential future healthcare needs, which are unfortunately increased for patients with cancer, and educating the public about the potential impacts of high deductible health plans on access to care and seeking care opportunities. I think these data also underscore the importance of potential policy solutions, and I wish I had the answers. I don't. But ultimately, I think we need to decrease costs of care that the patients see, in addition to reducing healthcare costs generally. Um, I hope we can limit the proliferation of high deductible health plans and similar plans, particularly for patients with cancer who I think needed additional protections. Um, but really, at the end of the day, I think we need to avoid disincentives for seeking what very well may turn out to be necessary and life-saving or life-prolonging care. Um, with that, thank you so much for your attention today and for being part of this. I'm always happy to chat. Feel free to reach out by email, Twitter, uh, and whatever. But yeah, looking forward to some additional discussion here.